Hello everyone, a very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I'd like to begin by acknowledging the Ngunnawal and Ngambri people, who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from. And I pay my respects to their elders past and present. We are pleased to welcome attendees from various parts of Australia and the globe, including India, Indonesia, Burma, Fiji, China, and South Africa. Knowledge is power, and our weekly webinar series allows us to share and learn from each other's experiences during the pandemic. Today, we have a very exciting speaker, Dr. Jason, and a very important topic, which I'll both introduce you shortly. I am Devashi, a medical student and volunteer for the ANU COVID-19 Peer Support Program, and joining me are my colleagues, Evangeline Wong and Bridget Nielsen, other ANU medical students who are also volunteering for this program, and Dr. Deepthi Talaulikar, who is a clinical hematologist and the program lead for the ANU COVID-19 Peer Support Program. Just quickly, a couple of housekeeping notes before we begin. All attendees have their videos and microphones switched off, and this just helps us keep the sound quality clear and reduce any interference during the webinar. I encourage all the attendees to ask questions, and the best way we can, because this is the best way we can interact with each other virtually. So to do so, please use the Q&A button, which you can see towards the bottom of your screen. If you do not wish to be identified, then you can submit your questions anonymously. And you can submit your questions at any point in time during the webinar. Dr. Jason will try to answer them as we go, but if not, we'll try and get to them at the end of the talk. There will be a webinar rating poll that will be launched at the end of the talk, and it'll appear on your screen. So please do select your preferred response. This just helps us with monitoring and evaluation of the program. And I assure you that all the responses will be recorded anonymously. Now, if you have any technical issues or questions after the talk, please email international.health@anu.edu.au, and we will try to assist you as best as we can. And finally, please note that this forum is being recorded. So today's webinar will be delivered by Dr. Jason Agostino on a topic that I'm especially keen to hear about. It's about Aboriginal on Torres Strait Islander peoples and COVID-19, a tale of two strains. In this talk, he will cover how leadership from Aboriginal and Torres Strait Islander people has been crucial during the pandemic. What steps were taken to protect the Aboriginal communities? What have been the challenges in the vaccine rollout in Indigenous communities? And what further needs to be done to protect the community as Australia opens up its borders? So Dr. Jason is a GP, an epidemiologist, and also the senior medical advisor at NACCHO, the National Aboriginal Community Controlled Health Organization. He has extensive experience working closely with the Aboriginal communities before and most crucially during the pandemic. And he sits on the Aboriginal and Torres Strait Islander COVID-19 Advisory Group and the Guidelines Leadership Group of the National COVID-19 Evidence Task Force. And we are so grateful to have you here, Dr. Jason. So with this, let's begin the webinar itself, and I'll hand it over to you.
Great, thanks, Devashi. While I'm sharing my screen, I'll just begin by acknowledging that I too am on Ngunnawal and Ngambri country and pay my respects to elders past and present, and extend that to Aboriginal and Torres Strait Islander people on the call. Thanks for the nice introduction, and it's nice to be here. I was just scrolling through the participants, and I could see a few of my mates on the call, which is always nice. So welcome to you guys. I think we went through all my different roles. I guess one thing that was left off is that when COVID is not around so much, I work clinically at an Aboriginal community controlled health service, and we'll get a bit about what they are up in a community in Yarrabah. And the name of my service is called Gurniyalamaka, which in the Gunganji language, which is the traditional owners of that place, it means healing waters. So before I started, I guess I just wanted to provide some context about where I'm coming from. You know, today's talking about Aboriginal and Torres Strait Islander peoples, the First Nations peoples of Australia. But I am non-Indigenous. You know, my background is my family's Italian, and they came here in the 50s. So, you know, I'm talking as a non-Indigenous man who has worked for Aboriginal and Torres Strait Islander peoples over the past decade across all my roles that I have, whether it's the uni, NARCHO, or in my clinic. I have bosses that are Aboriginal and or Torres Strait Islander, which is something that I find to be the best way to work. I'm also going to be talking more from the policy perspective. So whilst I'm a GP, as I said, I've been locked out of Queensland and the community where I normally work for most of the pandemic. And most of my work has been in setting national policy and also in being an advocate for Aboriginal and Torres Strait Islander communities. So my perspective today will be as through the policy things, and acknowledging that I've only been on the ground and working with the community for 2 weeks out of the whole 18 months. So with those two caveats away, I'll get started. And as we said, I'm happy to take questions as we go. It's a bit hard for me to see it on my little laptop, but keen to have our questions as we go along. So today, I wanted to just provide a bit of context about community-controlled health, particularly for international people here, because it is the crucial part to the response to COVID for Aboriginal and Torres Strait Islander peoples. And then talk about Alpha and Delta responses, because it's been very different for the community. Then we'll talk about the vaccine rollout, which has made a lot of news in Australia for the Aboriginal and Torres Strait Islander community, and what my organisation that I work for, NARCHO, sees as the priorities, and we'll have some more questions at the end. So, as I said, Aboriginal and Torres Strait Islander people are the First Nations people of Australia, and have the longest continuing culture in the world. I work within what's called an Aboriginal Community Controlled Health Organisation. There are 143 Aboriginal Community Controlled Health Organisations spread across Australia, and those dots on that map represent where they are, with over 550 clinics. So one organisation might have multiple clinics. My clinic, you know, for instance, my organisation has 3. And they also have a peak body within each state and territory. So there's 8 state and territories in Australia, and each has a peak body. And then NARCHO, who I work for, is the national peak. Now, what makes these organisations unique is that they are governed by a locally elected board that is made up predominantly of local Aboriginal and Torres Strait Islander peoples. And that then extends to our peak bodies. The organisations then vote for the board of their state peak body, and then in turn, they also have the opportunity to vote for the board of NARCHO, the organisation that I work for. We provide, even though there's only 143 clinics, or organisations, sorry, we do provide care to around about 50% of Australia's Aboriginal and Torres Strait Islander population. So over 400,000 people. And something that one of the deputy's chief medical officers within the Department of Health said once is that we are the only organisation in Australia that effectively combines public health and primary health care in the one organisation. And that's obviously been really important as we've responded to COVID. Now, the reason that we span both public health and primary healthcare is because we are trying to improve health according to an Aboriginal definition of health. And so this definition was endorsed by a predecessor to the NARCHO board back in the 80s, and it says Aboriginal health means not just the physical well-being of an individual, but refers to the social, emotional, and cultural well-being of the whole community, in which each individual is able to achieve their full potential as a human being, thereby bringing about the total well-being of their community. So what that looks like on the ground differs in each ARCHO, and that's because they all have different boards. But for my community that I've been working for over a decade up in Yarrabah, we've obviously got this core team, clinical team of doctors, of nurses, of midwives, of Aboriginal and Torres Strait Islander health workers, so what other countries might know as community health workers, and also more highly skilled versions of that, which we call Aboriginal and Torres Strait Islander health practitioners. And they're obviously we're often doing acute care and chronic disease care. But then we have a whole team addressing other things within the community. So we have a youth program, and we run a house for kids to come in after school to hang out and to sort of receive health education. We do cultural programs. We do a program called Bringing Them Home, which is about linking descendants of the stolen generations. So they're the people that were taken from their families and forcibly removed from their families and given to non-Indigenous families over a series of decades in the 20th century in Australia. And a whole bunch of stuff, including, healthy eating campaigns, smoking cessation campaigns on a community level. So we are really this organisation that really tries to do a lot, school programs, whole bunch of stuff. And it's an incredible organisation to work for. So that's the context of community-controlled health organisations that I work in. When COVID came, the community-controlled health sector was really worried. And this was an article that I wrote with a Aboriginal and Torres Strait researcher, James Ward, Professor James Ward at the University of Queensland, about the potential impact of COVID on Aboriginal communities at the start of the pandemic in March. The reason that we thought that it would devastate it is because previous epidemics have. We only needed to look back at the swine flu pandemic in 2009, where Aboriginal and Torres Strait people had 5 times, at a rate of infection 5 times that of non-Indigenous Australians, 5 times the hospitalisations, 5 times the intensive care admissions, and 5 times the rate of death, age standardised rate of death. So we were really concerned, and as was the whole of the community-controlled health sector. These 2 graphs sort of typify the main 2 reasons that we were really concerned. So 2 figures, sorry. So on the left, we have some data from the Australian Institute of Health and Welfare that's been cut off at the bottom. Okay, so that is looking at it's a Venn diagram of cardiovascular disease in the purple, renal disease in the green, and diabetes in the blue. And what it's showing is that in Aboriginal and Torres Strait Islander people, there is a high overlap of these conditions, and they also have their onset much earlier than non-Indigenous Australians, most often 20 years earlier than that of non-Indigenous Australians. So by March, we had a good idea that people with chronic diseases were more likely to have severe COVID-19 illness, and we have a population that has multiple of these chronic conditions from an early age. The second reason that we were really concerned is that too many Aboriginal and Torres Strait Islander people live in crowded housing. So this figure on the left is from the Australian Bureau of Statistics, looking at overcrowded households by urban and rural areas. So overall, 1 in 8 Aboriginal and Torres Strait Islander people live in crowded households. And you can see that in certain areas, particularly the Northern Territory, that figure gets up really high, towards 50% of people living in crowded homes. So that combination of a population with early onset of chronic illnesses, multiple chronic illnesses, and crowded housing was a recipe for disaster with COVID. Early on in the pandemic, we tried to quantify that a little bit. And so this is some work that was done with Katie Thurber and a team of social epidemiologists and Aboriginal and Torres Strait Islander clinicians across the country, looking at survey data from the Australian Bureau of Statistics. And what this showed was that around about 60% of all Aboriginal and Torres Strait Islander adults had at least one risk factor for severe COVID-19 infection. What we also showed was that not only was there a socio-economic gradient, but there was sort of also what we're trying to describe as a cultural gradient to that. So, people with the lowest income compared to people with the highest income compared to the lowest income obviously had less risk factors for severe COVID-19. But similarly, people that were not descendants of the stolen generations versus people that were the descendants of stolen generations also had less risk factors for severe COVID-19. And so what we're trying to make the point of is it's not an inherent, the risk of severe COVID-19 wasn't an inherent thing about being a First Nations person in Australia. It was because of socioeconomic and cultural factors. And, you know, in order to respond to it appropriately, we need to think about these things. So the community took action early, and, you know, one of the first things that happened was that NACCHO and other community-controlled health organisations called on the government to form a specific advisory group on COVID-19 for Aboriginal and Torres Strait Islander peoples. So that actually started in early March, which for us in Australia was quite early in the pandemic. For Australians on the call, it preceded National Cabinet, it preceded the Formula One being pulled off, which was sort of marks a moment in time in our history of COVID. It's co-chaired by the Australian Government Department of Health and by my boss, Dr. Dawn Casey at NACCHO. And what we have is representatives from every state and territory Department of Health and every state and territory Aboriginal peak body, as well as a number of experts in Aboriginal and Torres Strait Islander health. And today we had our 93rd meeting. We've been meeting at least weekly over the pandemic to think about targeted responses for the community. In addition to that sort of policy response, the communities themselves, in particular our community-controlled health organisations, just flooded social media and their communities with health messaging. Well, I'll bring up some examples in a second, but it was just incredible, the rapidity and the appropriateness of the messages going out to community at a really early stage. One thing that was applied to remote communities is that we evoked the Biosecurity Act to lock down the remote communities of Australia. So most Aboriginal and Torres Strait Islander people live in urban and inner regional areas, but the people in the remote communities have the highest rate of chronic diseases and the highest rates of crowded housing. So we wanted to protect those communities in particular, and those communities called for them to be locked down. So you can think about these multiple layers of protection. You know, Australia locked down its borders, each state and territory locked down their borders. And then within that, you couldn't get into remote Aboriginal and Torres Strait Islander communities without specific permissions, even if it was in your own state or territory. And that applied for around 2 months from March through to May in most communities. We looked at improving access to testing, and that was in response to reports of racism for Aboriginal and Torres Strait Islander trying to access testing. Testing was limited at the early stages, but Aboriginal and Torres Strait Islander people were an early priority after healthcare workers, and people were having their identity questioned and receiving racial slurs when they were accessing testing. So we had to address that. And in Australia, COVID coincided with, well, not coincided, was led to the rapid expansion of telehealth as a model of care for primary healthcare. And we had to make sure that this new form of consultation could meet the needs of our community-controlled health organisations. So the main output really from the COVID-19 advisory group was a specific national guidance for Aboriginal and Torres Strait Islander peoples. In previous pandemics, there had been no specific targeted responses for Aboriginal and Torres Strait Islander communities, you know, and so it was unique that early on, this came out in April, we'd created guidelines that for states and territories to look towards about how they would address COVID in their communities, which, you know, included things such as specific modelling done based on the characteristics of Aboriginal and Torres Strait Islander communities. These are just some of the examples of that messaging that I talked about, and this was all coming out through mainly through social media. The community is really connected, and when we get to vaccines, we'll probably talk a little bit about the someone asked a question about update of telehealth, and I'll get to that. Okay, and you know, people will criticise the role of social media in vaccine hesitancy, but it's important to note it's not social media itself; it's how it's used. And definitely at the starts of the pandemic, it was used extremely effectively by our Aboriginal community-controlled health organisations. This is some diagrams and messaging that were made by our Western Australian peak body. This is Dr. Mark Wenatong, who was one of the first Aboriginal people to become a doctor in Australia, and is a senior doctor up in Cape York in the northern part of Australia. And he would do these amazing videos just speaking directly to community about how to keep them safe. And this is an example of, communication material made in language by the community themselves. And this, later in the pandemic, when COVID was ripping through culturally and ethnically and linguistically diverse communities, there was often this criticism that there was no appropriate message about how to keep safe. And that was just not the case with our services. We were well equipped to develop health promotion materials. We've been doing that with things such as smoking prevention and STI prevention. And we got out there quickly, which made a big difference. The other thing was about improving access to testing, as I said, and there needed to be different responses depending on people were urban or in rural and remote communities. So in urban areas, what we did was many of our services in urban sites became what are called GP respiratory clinics. So dedicated sites where people in Australia go if they had respiratory symptoms, where they could get properly assessed, where that clinic was pumped full of, personal protective equipment. And so 23 of our services became that, and it was about 15% of all the sites in all of Australia. And they've done hundreds of thousands of tests, not only for Aboriginal and Torres Strait people, for non-Indigenous Australians in their community. In rural and remote, it was a different issue. And the biggest issue there was that for these places in the middle of Australia, it's hard to, give you an idea about how big Australia is and how remote some of these places are. But it was taking up to 10 days to get a COVID result at the start of the pandemic due to problems with transport that were exacerbated by the fact that standard transport routes stopped. So 10 days to get a COVID result is about 9.5 days too long. And in response to that, we started using gene expert machines. In a sort of role of a bit of luck, we already had 30 of these machines placed around our clinics as part of a trial on STIs. And we quickly changed them over to test for COVID. So it's a PCR test and provides a result within 45 minutes. And it has research partners with the Flinders University and Kirby. And they provide a lot of over-the-phone support about quality assurance, and also when people get positive results. And so rapidly expanded, or switched these 30 sites over to COVID testing, and then added an addition over more than 50 more sites to that program, and really just changed the game in terms of quick results for COVID-19. And at that stage, it was the first instance of a nationwide point of care testing program focused on remote areas. With telehealth, we needed to make sure it addressed our model of care, which is team-based care. And so we needed to make sure that not only GPs could use telehealth, but so could Aboriginal and Torres Strait Islander health workers and health practitioners. So could our allied health practitioners, and have additional visits. And also a big part of what we do is what's called a health assessment, where we do top to tail. So over the year, even though Australia was relatively, apart from Victoria, stayed fairly COVID-free in the first year of the pandemic, telehealth was used for 10% of all consultations, lifting up to about 20% in the Victoria. And that's pretty similar to what you see for the pattern for the non-Indigenous population in Australia. Importantly, it's basically all on phone, not with video capacity. And I'll get to a bit about when video is used later on. The impact of it was that it helped prevent a drop-off in preventative health activities. So, because we have this high burden of chronic diseases, it's not just about focusing on COVID, it's about thinking about preventative diseases and making sure we stay on top of them. So that 10% from telehealth meant that we were pretty close to keeping the same amount of activity in terms of health assessments during the first year of the pandemic versus 2019 to 20. And we actually had more follow-up with practice nurses and Aboriginal and Torres Strait health practitioners. Everyone was quite an enthusiastic user. And if you think about the sort of role of telephone telehealth, follow-up of patients is an excellent use of it. So we've seen that through the pandemic, follow-up actually increased by over 10%, which was great to see. So the sum total of that was that we just had an extremely successful response in the first year. There were only 153 cases. And to put that in perspective, the rate of infections amongst Aboriginal and Torres Strait Islander people was 6 times less that of the non-Indigenous population. So for a highly disadvantaged group that had so many risk factors, it was just really an outstanding outcome. And we have had 0 deaths during Alpha with no transmission in remote communities. People can be a little bit dismissive and be like, oh, they weren't involved in any of the outbreaks, but they were, like Aboriginal and Torres Strait Islander people. There's a large community in inner city Melbourne, in the towers that were locked down for people that know the Australian outbreak. In Melbourne very early in their pandemic, there was many Aboriginal and Torres Strait Islander families that were in there, and they were just incredibly well supported by the community to safely isolate at home. Similarly, when the New South Wales outbreak started in southwest Sydney in 2020, again, that's a large Aboriginal and Torres Strait Islander community, and again, they were able to keep Alpha out of their communities. And we also there were instances where early in the pandemic where doctors had travelled up into some remote communities and were COVID positive, but thankfully didn't pass it on. In addition to having very few cases, it appeared that we'd had really little disruption to preventative care and management of chronic disease, particularly for older people. It looks like the number of primary healthcare consultations for older people was maintained or even improved during the first year. There was some evidence there was decreased preventative activities in the younger population, though, and we've still got some catching up to do that obviously is going to become even worse with as we're now dealing with Delta. All right, I'll talk about the telehealth stuff at the back. So yeah, as I said, the talk's called The Tale of Two Strains because the response to Alpha was highly successful, and the response to Delta has shown why we were so worried about the potential impact on Aboriginal and Torres Strait Islander communities. So in Australia, the Delta strain picked up in New South Wales in the middle of June. And in that early stage, there were a few, about 100 cases amongst Aboriginal and Torres Strait Islander people in southwest and western Sydney. But it really kicked off when a case was identified in a town of Walgett. So Walgett's considered a remote community in Australia. It's in the northwest of the state, and God knows how many hours away from Sydney, a long time away from Sydney. When that case was picked up in Walgett, simultaneously, they then identified that there were cases in Dubbo, a larger rural town in Western New South Wales, and all the way out to Wilcannia, which is a small remote community of less than 1,000 people that sits way out in the west towards the border with South Australia. And this was an article in the conversation by one of our ANU PhD students. And, I think the title sort of says it. It was sort of the crisis in Western New South Wales was a nightmare realised, and one that we've been worried about since the start of the pandemic. One of the reasons that it was a nightmare realised was that even though we had been talking about this problem with accommodation and inability to safely isolate if someone was a positive case, nothing had really been done to address that in the 18 months that we stayed relatively COVID-free. In a because it was so obvious, I guess, you know, in our submission to the Senate Committee on COVID-19, we actually used, NACHO used Wilcannia as a case study. And we said if COVID-19 was introduced in Wilcannia, it would be impossible to contain due to overcrowding, poor sanitation, and a lack of resources needed to quarantine properly. And that's what happened over a year later. There weren't appropriate accommodation options for people. People were quarantining in tents. People were complaining about inadequate food and food insecurity whilst they were trying to isolate. And it wasn't until 3 weeks into the pandemic that alternative accommodation was brought in the form of motorhomes for those communities. In the end, over 200 people in a community of about a bit over 700 have been COVID positive. The great thing is that no residents of Wilcannia have passed, despite that caseload, and we'll get to the reason behind that a little bit. So, as I said, when that first case happened, we were still only at about 250 cases across the country, and as of yesterday, we're at 5,300 cases amongst the Aboriginal and Torres Strait Islander community, with most of those cases happening in New South Wales, over 4,500. The rate of infection through Delta has been twice that of non-Indigenous Australians, and basically what we're seeing is that we just have rolling outbreaks in, you know, first it really started off in Western New South Wales, and then it started being, the focus started being the western suburbs of Sydney, and then in the last few weeks it's been, for people in Australia, it's people in Newcastle and Tamworth where we're now seeing these outbreaks. And the reason that we're seeing so many outbreaks is that, unfortunately, Aboriginal and Torres Strait people where they live share these common risk factors about too much crowded housing as the main thing. And at the moment, this vulnerability in that there's still relatively low vaccination coverage. It's spread into other parts of Australia. So where we are here in Canberra, it's not really well known, but 10% of all the cases here in Canberra are amongst Aboriginal and Torres Strait Islander peoples, even though they make up less than 3% of the population. And in rural Victoria, we're seeing quite a lot of cases as well. So it's spreading, and it's obviously a really big concern. I'll talk about that one later as well. Sorry, I was just looking at the questions. I can't get back to my screen now. Oh gosh, how annoying. So this is looking at the distribution of the cases. And so we wait until at least 2 weeks have passed to talk about disease severity because of the natural history of COVID-19. So these are data from the 26th of September for the Aboriginal and Torres Strait Islander population, and for the general populations from over a month ago, and that's just because there's been a bit of delay in publishing it. The Aboriginal and Torres Strait Islander data, I haven't displayed it all. It'll be published in the next national report. So I've just shown you the percentages here. What this shows is that the cases are young. So 80% of cases are under the age of 40, under the age of 40, and around about 40% of cases are in children and teenagers. And that in part reflects the younger demographic of the Aboriginal and Torres Strait Islander population in Australia. The average age is 23, whereas for the non-Indigenous population, it's well over the mid-30s. And so, as you can see, a big difference in the young people being infected with COVID-19 compared to the non-Indigenous population. The other row that's highlighted is the 40 to 60-year-old age group. And that's because at the moment, most of the deaths that have occurred amongst Aboriginal and Torres Strait people have been in this age group. And we're seeing about 1% of cases dying, which is around 3 times higher than what we're seeing in the non-Indigenous population. So a big concern, and something that we were always worried about because of that high prevalence of chronic disease. For the older population, at the moment, the proportion of cases has remained similar to that of the non-Indigenous population. And what I think that is attributed to is that we do have quite high vaccination rates amongst this group. So there is a large gap nationally between vaccination coverage for Aboriginal and Torres Strait people and non-Indigenous Australians. It is much less in the states that are currently affected by COVID-19. So that's the states on the left, ACT, New South Wales and Victoria. So with this graph showing a few things at one time. So the yellow dots represent first dose coverage for 60 and over, greys for 40-59, reddish for 20 to 39 and blue for the 12 to 20-year-old age group. And then we've got all the different jurisdictions, and their state average is displayed there for first dose coverage for Aboriginal and Torres Strait Islander peoples. So in the states with the pandemic currently going on, they're sitting at above 70% first dose coverage, but importantly, for that over 60 population, it's pretty close to 90%. And, I think that's contributing to the lower than expected cases and lower than expected deaths in that age group. And it's pretty good in the 40 to 59, but that's had a lot of catching up that it's done since in the past 2 months. It was much lower. The big work needs to be done, obviously, in those states where there hasn't been much COVID, and where we'll get to some of the reasons that we're seeing it, and particularly in the younger age group. So as I said, the average age is 23. And so those red and blue circles, that's where the most population is. And we really need to get those vaccination rates up, because without that, we're going to continue to have, an unvaccinated population that is going to be circulating COVID between them and their children under the age of 12 and posing a risk to their whole community. So there's been a whole bunch of strategies to increase vaccination. I think we're trying to address complacency, hesitancy, and misinformation. So in terms of complacency, many Aboriginal and Torres Strait people outside of the southeast states of Australia are pretty unaware of how badly the community has been impacted through Delta. I was texting a good friend of mine who works in the health sector and who's up in Queensland and hasn't really, and far north Queensland. And she was unvaccinated or is unvaccinated, and was sort of saying to me, "Oh, look, I'll get it done." And I said, "Mate, it's going to take 6 weeks until you're fully covered, from your first dose." And this has happened in the past 6 weeks. And I listed the number of cases, hospitalizations and deaths. She was like, she was just stunned. And it was stunning to me that she was unaware of the impact that it's having in the community. As someone who's very health literate, works in the health sector, even she was unaware of what's happening down south. So what we're doing is we're developing community-focused infographics and really pushing for the government to publish these data broadly. Unfortunately, at the moment, I'm the main source of cases and severity data, which is not ideal. In terms of hesitancy, we've done a lot of work's been done. There's been community forums. We've had a lot of videos from First Nation leaders. But really, what's happening more and more in these communities with the high levels of hesitancy is that people are going door to door. So in the community where I work in Yarrabah, last week, they went door to door over 3 days, and each day they vaccinated more people in a day than they normally do in a week. And that's the hard work of listening to people's concerns and addressing them over time. And in addition to that, there's been specific misinformation campaigns targeting Aboriginal and Torres Strait people. So some have come from fringe religious groups, some have come from right-wing groups that are targeting Aboriginal and Torres Strait peoples. In terms of addressing the message from religious groups, we've been working with mainstream religious leaders who are Aboriginal and Torres Strait people and supporting them to address misinformation within their congregations. And there's been some great messages about vaccination being an act of love, consistent with the Christian tradition. And yeah, we continue to work with them to address the misinformation circulating. So what has worked? Because it has worked, and we've quadrupled the number of weekly doses going to Aboriginal and Torres Strait Islander peoples in the past 3 months. And key to that has been moving away from vaccination based in state hubs to primary healthcare. And there's lots of reasons why vaccinating through primary healthcare makes a lot of sense. We have trusted staff, you have support for transport, and general practices are reaching out and calling their at-risk patients and going to their homes. The early part of the pandemic was the vaccine rollout, was dependent on these urban located vaccine hubs, that were run by state health clinics, and there wasn't any outreach into the communities. There wasn't any specific things to help them get there, and the result was that they delivered very little vaccine to Aboriginal and Torres Strait Islander people in those first few months. The other thing is about messages from the community, not from governments. It makes, if you are from a culture that has survived attempted genocide on your peoples, it makes sense to distrust the government. And we see this across multiple cultures across the world, that they have suspicions about this vaccine, and that they're trying to make you infertile, or using you as a guinea pig. And thinking of the history of mistreatment and the ongoing mistreatment of Aboriginal and Torres Strait Islander peoples, it makes sense not to trust the government. And it hasn't helped that at the start of the vaccine rollout, the government was trying to centralise the messaging, and it was sort of stifled the creativity that we saw at the start of the pandemic from our health services. So we didn't see the same flood of information, because some messages came out from the medicines regulator in Australia, sort of discouraging advertising of the vaccine. And advertising of vaccines definitely should be discouraged, but health promotion shouldn't. And it had that messaging to stop advertising had the unintended consequence of making our services scared to put out their own messages, and really stalled their messaging in the first few months of the campaign. That's now been addressed, and we've worked with them through that. And now we are starting to see those messages, and there's been some great messages coming through, but it started on the back foot, and we really need to continue to have these messages from community, not from governments. And when we've been going into emergency responses, just a shout out to some of my colleagues at ANU who went out and supported AUSMAT, which is an emergency response team that typically responds to international emergencies, but has been used in the Western New South Wales response. But they weren't very culturally safe. And so 3 of my colleagues at the ANU went over and worked with them, worked with the communities to make sure that things were being done in the right way. And they saw a much higher vaccine uptake when they were involved. And we're trying to use that sort of response in the future. So moving forward, we are working as hard as we can to increase vaccination as quickly as we can, and obviously been quite successful in the pandemic hit states. But a lot of work to do still in the other places. And the reality is, regardless of how high we get the vaccination levels, because of a very large population under the age of 12, and because of crowded housing, we will continue to see, outbreaks within Aboriginal and Torres Strait Islander communities. So we simultaneously need to lift vaccination rates and improve our pandemic responses. So the first is, really what I was talking about, highlighting the importance of COVID and how it's impacting communities now and how it will impact communities. We've had ongoing problems with workforce. There's been this drain of our workforce from primary healthcare and into state-run vaccination clinics and testing clinics, where the pay is more attractive, and the conditions are probably a little bit better as well. So in terms of not as complicated work. And there's a lot of people like me who live in one state and work in another and haven't been able to work. And there's a lot of people from New Zealand that actually come and work in Aboriginal and Torres Strait Islander communities that haven't been able to get here much either. Even though we've done so much work on testing, I think we need to do more. And the big thing where we're not really thinking about it appropriately is the use of rapid antigen testing and how that can especially help in whole of community responses if we're going around and trying to test a whole community at the start of an outbreak. We also want to see improved access to novel therapies, with sotrovimab being one of the big ones. It's only been one randomized controlled trial, but the evidence from that was quite impressive. And, in New South Wales Health, they've recommended that it be considered for use in all Aboriginal and Torres Strait people 35 and over, and in younger if they've got comorbidities. But because, it has to be given as an infusion, we're dependent on availability and accessibility, particularly in rural and remote communities. So we want to make sure we can have access to those therapies. And we want to have appropriate telehealth. As I said, most people access telehealth over the phone. But the one exception is in our remote communities where they've developed their own novel method for using it. And what's happening is that the community member is still coming into the clinic, and our local health workers or nurses are supporting them to use the technology to then dial in to see a remotely based GP or physiotherapist or a specialist or a psychologist, and sitting in with the consult to make sure, to help the patient if they're having problems with understanding or with the technology. And that's really in-depth work, but none of that work's funded. And the other thing is that the government recently cut off all of the longer items unless you were using a video. And they just don't seem to appreciate that for many people across Australia, Aboriginal and Torres Strait people and non-Indigenous, video, both the technology, like the hardware to use it, to have it, the connectivity to use it, and the credit to use it is just out of reach. And so we need to improve our use of telehealth and make it appropriate for Aboriginal and Torres Strait Islander peoples, because we're going to have to rely on it as we continue to deal with all these outbreaks. And probably most importantly is that we really need to improve the pandemic responses. The response through Western New South Wales has shown problems with accommodation and food security, and local organisations have said that they felt left out of the decision-making process. And that's not the way it should be. In Australia, we have what's called the National Agreement on Closing the Gap, which is an agreement between Aboriginal community-controlled peak bodies and all levels of government. And they agreed to 4 priority reforms. And the first reform is around shared decision-making. And, there's evidence of that happening with us at a national level. It can obviously be improved, and we're working on that. But for local community-controlled organisations to feel left out of decision-making is, you're not going to have the appropriate response with them locked out of it. So I think that's where I finish. So, and I'll go through the questions. Who wants to, do I just read them out and go through them?
I can help you with that. Jason, firstly, I just want to thank you for such a good talk, very data informed on the impact of COVID-19 on Indigenous populations. Very typical of you being an EVM lecturer. But yeah, you gave a really good overview of so many topics, highlighting the importance of socioeconomic factors, the structures that were put in place to support the communities, the strategies for increasing vaccination. And given the geographic scale of Australia, door to door, wow, that's a massive effort. And the thing that stuck really to me was what you said about vaccination being an act of love, and that positive messaging is so important to break down the misinformation. So we've got a couple of really good questions that have come up. I encourage all the attendees to submit their questions using the Q&A button at the bottom of your screen. So the questions on telehealth, Jason, did you want to add anything more on that? So the first one was, how's the uptake with telehealth for Aboriginal and Torres Strait Islander communities? And the second one was, could you please highlight the challenges which were faced in implementing those? Anything else you want to add? You talked about.
Look, I think I talked about the uptake. So it's about 1 in 10 consultations, and it's all been telephone. I think the main thing is that for all clinicians, the video infrastructure has been a real challenge, and it's particularly challenging for Aboriginal and Torres Strait people who, as I said, lack the connectivity or the credit to use it. And our services have adapted and developed this model where the patient comes in and uses the clinic's video facilities to access a remotely based clinician. And I think it's a great model of care, which is potentially even more high quality care than other forms. So, so I think they've done a really great job.
Yeah, definitely. The next question is, mental health has been a big issue for the wider population during the pandemic. What culturally appropriate support services, positive messaging or resources were put out in place for Aboriginal people?
Yeah, so you're right. So mental health has been a really big issue for Aboriginal and Torres Strait people as well. Many people have been prevented from participating in cultural activities. They're highly connected communities, and people, some people haven't gone to their community where they're from and to see their family for a long time because of state borders and other restrictions. I think it's a good question, and our services, as I said, we're comprehensive primary healthcare, so we already have our mental health services. I think the challenge has been that any boost to mental health services has not gone directly to them. Okay, so it's been this real big challenge, and you've seen in Victoria, there's sort of been these mental health hubs, and none of them were community-controlled organisations. And so I think that's a real failure of the response at the moment, is that not enough has gone directly to community-controlled health organisations to address mental health concerns. So I think it's an area that we're all really aware of and have been calling for greater funding, so that basically we just want to give the money for our services to be able to do the jobs that they do such a good job at.
Right. Yeah. Thank you for answering that. Another attendee has asked, what do you mean by culturally safe?
Yeah, cool. That's a good and a big question, and a hard question for a non-Indigenous person to ask. But essentially, what I understand it to be is that culturally safe means that you feel safe to practice your culture in front of another person. So I think and not to hide parts of yourself and your culture in a consultation, and to talk explicitly about things that someone from another culture might think is different and weird. So it's really about creating an environment where a person can be themselves and talk about things that are important to them without the fear of persecution.
I think that was very well explained. The next question is, looking back, what else do you think we could have done better for the Indigenous communities?
Look, at the end of the day, this is about, the spread of COVID is about housing. So we could have done something over the past, how many decades to address the housing supply to Aboriginal and Torres Strait peoples, and also the quality of housing. I didn't really touch on what we call as inadequate health hardware. So, in Yarrabah, where I work, many houses don't have functioning washing machines and proper hot water systems and things like that, So as well as having just in Yarrabah, many houses have, over 10 people in 3-bedroom homes with multiple generations. So that was the biggest thing. We could have invested in more appropriate alternative accommodation for people in lieu of appropriate housing. And also, I don't think it's been explained to the community why that is important, because even when it's been available, it hasn't been taken up much. So I think some communities had put out options to the government and that weren't funded for alternate accommodation within their community, because they wanted to keep people within their community. So I think that's probably the biggest thing. I think there's been a few things that have happened through the vaccine rollout that you want to change, and that's coming up as a question, so I'll leave that for that. But for us, at NACCHO, our focus is on housing and making sure that person doesn't have to isolate in a crowded home if they have COVID.
Yeah, absolutely. Given the importance of these socioeconomic factors, it seems like there's work to be done still.
Yeah.
Okay. The next attendee has asked, which strategies were effective in dispelling COVID-19 vaccine misconceptions, if any, among Aboriginal and Torres Strait Islanders communities?
Yeah, look, it's been multiple things. There's no one strategy works everywhere. I think the one method that works is for a health worker, like a staff member that people know and have a relationship with, or a community member that people know and have a relationship with, to have the time to talk to people about their questions. You know, I don't see many anti-vax people within the community. I see people that are hesitant and rightfully skeptical of government and want their questions addressed. And so, you know, listening to my colleagues who went out to Western New South Wales, they were part of that door-to-door. That's what they were doing. They were listening to people. They weren't known, but they would introduce themselves, talk about where they're from, where their families are from, and then they would just listen and then address people's concerns. And I think that hard one-on-one work is what has gotten so many people over the line, and it continues to do it. It's just hard work. People, I think, wish that there was some TV campaign that would make it all go away, but when you for centuries have been mistreated by government and also mistreated by medical research organisations, you have to remember that Aboriginal and Torres Strait people have had inappropriate medical research done of them in their recent history, you know, in living history. To address that type of mistrust, that well-deserved mistrust, takes time. And yeah, that's been the most effective way, is to take the time with a knowledgeable and trusted Aboriginal and Torres Strait person.
Yeah. Great. Janet has asked, Aboriginal and Torres Strait Islander people were meant to be high priority for vaccines, but what went wrong? They clearly haven't been.
Yeah, so I guess there's things about, there's a few things. You know, I guess the first is that the whole rollout into primary healthcare was based on AstraZeneca, and within 3 weeks of the primary healthcare rollout, that had, you know, we've made the recommendations in Australia that for people under the age of 50, that Pfizer was the preferred dose, and there's not actually that many Aboriginal and Torres Strait people over the age of 50, and even less when they changed it to over the age of 60. So we became dependent on Pfizer because, you know, this is also occurring in the context of low community transmission and not many people under those ages taking on AstraZeneca. As I said, the state clinics didn't work for Aboriginal and Torres Strait peoples. I don't think they work for people with disability. I don't think they work for people with mental illness. I think they worked for people like me who are highly digitally literate and live in an urban setting. So for a couple of key weeks there, we were highly dependent on state clinics, and they weren't reaching out to Aboriginal and Torres Strait Islander populations. You know, and then, as I said, you know, I think, you know, understandable messaging around by the medicines regulator, the TGA, around vaccine advertising, you know, had an unintended consequence that stifled some of our communication early on. But I think it is important to stress that, you know, our services, my community control health have been prioritised in the primary healthcare rollout for both AstraZeneca and Pfizer. We had a huge amount of AstraZeneca in our clinics. We were able to give 30,000 doses a week across our clinics in the first couple of weeks, even as soon as AstraZeneca became available. And we were the first services to roll out Pfizer when it became able to be stored in primary healthcare. So those things have been prioritised for sure. But, you know, I think what is clear is that everyone needs to prioritise Aboriginal and Torres Strait peoples and not just leave it to 143 organisations. And I think what's happened in New South Wales and ACT and Victoria through the pandemic response is that everyone has been getting behind it. We've seen really great responses from the state health departments and from the Royal Flying Doctors. So that's what, in Western New South Wales, they went from 20% first dose coverage to more than 70% in a 4-week period, which was incredible and great and needed during the middle of an outbreak. So, I think when everyone starts working together, and when, particularly when state health contribute their resources to our health services and to other community-controlled organisations, that's when we get the best outcomes.
Yeah, definitely. No, that's very impressive. Reaching 70% and 30,000 doses per week. Wow, massive. And yeah, I agree, it's in collective effort. Excellent. So I think that's it for questions. I'm just going to put another call out for any other questions if you'd like to ask attendees. If not, then I'll wrap up the presentation here. Jason, can you unshare your screen? I'll just quickly share my screen and wrap up with a few slides. Cool. Any other questions? No. Okay. All right. Okay. Yeah. Another round of thanks to Jason for taking out the time to give us this presentation today. I'm sure that all the people who watched the webinar live and those who will be watching it afterwards, since the recording will go up on the website, they'll all find it quite informative and quite educational. A poll has been launched for everyone. Please rate the webinar. This is just for our monitoring and evaluation purposes, and we very much value your feedback. I want to put a quick note on the next webinar, which will be delivered by Dr. Rohini Sridhar on challenges in delivering healthcare during the COVID pandemic, the Apollo experience. And if you'd like to register, here's the link, but we will also be sending it